Good morning, everyone, and welcome to the October webinar. We have one housekeeping item today. We would like to let everyone know that you can ask questions of the speaker at any time during the webinar by writing the question into the questions pane on your GoToWebinar side panel, and the speaker will be taking all questions at the end of the webinar. Our presenter today is Dr. Mikael Boberg. Mikael is part of our Early Career Investigator Initiative, and we are very pleased to have him here. We were intrigued by his work in a vulnerable population and the use of modeling as an alternative to a clinical trial. Dr. Boberg is a pharmacist with a PhD in PKPD modeling and simulation. Mikael finished his PhD studies at the University of Gothenburg in 2022, and he is now based at AstraZeneca R&D. Mikael is part of the PKPD modeling and simulation team at the Research and Early Development Cardiovascular, Renal, and Metabolism unit in the Drug Metabolism and Pharmacokinetics function. And I'd like to give a very warm welcome to Dr. Mikael Boberg. Welcome, Mikael.
Thank you very much, Rebecca. Glad to be here, and let me start by thanking you for inviting me here. It's been almost, I counted it was many months ago we first had this call for early career investigator webinar applications. I'm very happy to be one of the lucky ones to present, and so I'm very thankful for that. And to all attendees, very welcome to this webinar. So today we will talk about pharmacokinetics and pharmacodynamics, so PKPD, and we will have a big focus on the modeling part. And we will talk a lot about this drug called eflornithine. And eflornithine is one of the recommended treatments against a fatal parasitic disease. This disease is found in Africa, so the most vulnerable population and most rural parts of the continents, and I will show you more about that. So just to be clear, I did my PhD at the University of Gothenburg. My PI was Professor Michael Ashton, and I of course want to acknowledge him, and of course my co-supervisor, Dr. Rasmus Jansson Löfmark, who we have been working closely together throughout my PhD and then beyond. And my current affiliation is now with AstraZeneca, but the work I will present here with the PKPD modeling of eflornithine is based on the work from my PhD. So with that, I would like to show you our outline for today's talk, where we will firstly discuss the disease area, human African trypanosomiasis, or HAT. And we'll also talk about the drug eflornithine, which is one of the current recommended treatments. And then we'll dig through these 4 different parts where we'll look at the in vitro activity of eflornithine, so lab bench work from my end. And then we'll look at population PD modeling using these findings from the in vitro study. Moving on from there to in vivo work, where we looked at the PK in Sprague-Dawley rats for the racemic eflornithine, but also one of the enantiomers. And together we have then these 3 parts that are combined together with available clinical PK data from humans, where we have plasma and cerebrospinal fluid data, and trying to combine that and with a modeling and simulation approach, then give recommendations towards the clinic on both doses and dosing regimens, but also what route to take when it comes to combination treatments, which is not uncommon for parasitic disease. So from there, let's start with the first part, where we talk about the disease area. So human African trypanosomiasis is a parasitic disease, and it's a vector-borne disease, which means that it's spread via a fly. It's called a tsetse fly, and when this fly is biting a person and the fly has parasites in it, the person then gets infected. And there are two types of parasites. So we have the western part, or the gambiense type of parasites, and then we have the rhodesiense type of parasites who are located in the eastern parts of the continent. And this is a general map. Of course, there is possibilities of overlap, but this is a publication from Kennedy back in 2008 showing the general locations. And these parasites come from the strain of Trypanosoma brucei. So we have Trypanosoma brucei gambiense and Trypanosoma brucei rhodesiense parasites. So once a person gets bitten by a tsetse fly, the parasites start to develop in the systemic circulation or in the blood. So initially the patient has quite vague symptoms, fever, malaise, and it can be very vague and very hard to diagnose a patient with early stage HAT. But over time, the parasites multiply and can then invade the central nervous system. So then the patient has developed late stage HAT. So now you have symptoms with more neurological nature, more severe, of course, with convulsions, tremor, and over time the patient then gets so ill, so falls into a coma, and without treatment, the patient dies due to the parasitic infection. There are available treatments out there, and here's a list of those available treatments. So on the top here we have fexinidazole, which is a major step for the diseased population here, where fexinidazole is based on great work from the Drug for Neglected Disease Initiative, and that was approved back in 2018. So it's the first drug in many, many years to come for this diseased population. Then we have a combination therapy, which is based on two drugs, so nifurtimox and eflornithine. We'll talk more about eflornithine here today. So the nifurtimox-eflornithine combination therapy is also great work from the Drug for Neglected Disease Initiative, or DNDI, where you combine the two drugs and have good efficacy. Other options are pentamidine, mainly used for early stage, and then eflornithine monotherapy is still on the list, even though NECT would be preferred, I'd say. And then the last one is melarsoprol, which is classed as an old drug, still on the list, but melarsoprol is arsenic derivative and comes with severe side effects, as you can imagine. So both the parasites die from this drug treatment, but also patients can actually die. So there's a proportion of patients who develop some type of inflammatory response due to the drug and can actually die due to these side effects. But let's zoom in more on eflornithine, and we're going to talk about both the combination treatment and monotherapy. But let's start off with some chemistry just to set the scene, as eflornithine is a drug that has a chimeric center here. So depending on if the molecule has a nitrogen here in blue that is pointing inwards or outwards, you have D or L-eflornithine. So these two enantiomers might be different. So the big question is, for my PhD studies and then also the community working with eflornithine, is, are these two enantiomers different? And if we look at the PK or the pharmacokinetics, if you would dose these two intravenously, you have similar pharmacokinetics. So same volume of distribution and clearance and half-life and so on. So no real big difference there. However, if you would dose the racemic mixture, which is a 50-50 mixture of D and L-eflornithine, you would see higher exposure of D-eflornithine. It's about 2 times more D-eflornithine that is taken up or absorbed compared to L-eflornithine. So we have a difference when it comes to the absorption part in the pharmacokinetics. And the eflornithine is used to treat late-stage gambiense human African trypanosomiasis, so the Western type of parasitic infection, and it's used in the late stage. So when the parasites have invaded the central nervous system, eflornithine is one of the options you can go with as a clinician to treat your patient. So from here, let's jump over to the lab bench and the collaboration that we had with the Swiss Tropical and Public Health Institute and University of Basel, where we worked together with Professor Pascal Meser, Dr. Marcel Kaiser, and Monica Kahl. And if you want more details around this work, you can see the published paper. I have the reference down there. But what we did here in this work is that we had 3 different strains of parasites. So we had, and they're all Trypanosoma brucei gambiense parasites, but they come from different patients or isolated from different patients with STIB 930, KO3048, and 130R. And what we did in this study was that we incubated the parasites together with isolated L-eflornithine, D-eflornithine, or racemic mixture. And I have this picture here of this 96 well plate where you can see that we have highest drug concentration on the left-hand side and dilute that down, and then compared it to control wells where we have parasites without drug treatment, but also the media that the parasites grow in to get fluorescent signals for that. So in this assay, the Alamo Blue serial drug dilution assay, you get the fluorescence as a marker of if the parasites are alive and well, or if the parasites are gone. So here are the results from this work, where you see 3 things. So the coloring is for racemic eflornithine in blue, with observed data are the dots, L-eflornithine in green, and D-eflornithine in red. And if you look at the plot here, you have parasite growth, as I said, measured as a fluorescence in this Alamo Blue serial drug dilution assay. And with a value of around 3,000, it means that the parasites are alive and well. And with a value of about 1,000, there is the baseline, where it's mainly only the media left that gives the value of 1,000. And it's quite amount of D-eflornithine you need to get a growth inhibition is higher compared to racemic eflornithine in blue or L-eflornithine in green. And then we modeled this data using a regular Imax function, where I0 is then the inhibition we see at 0 drug concentration, so basically the value of 3,000 there. And then we have Imax function that is driven by the concentration of drug we see. There we also have IC50 and gamma to describe the steepness of this concentration inhibition relationship. So from this model, we then get the parameters, and here I have the overall parameters we also have for the specific strains, but the message is still the same, independent of what strain we look on or if we look at all of them combined. So if we look at the potency, here is measured as the IC50, and these are now in micromolar concentrations. You see that to have a 50% growth inhibition, you need 9.1 micromolar of racemic eflornithine and 5.5 micromolar of L-eflornithine, so a lower value there, which means it's more potent. And if you compare D and L-eflornithine, D-eflornithine, then you need 50 micromolar compared to the 5.5. So we concluded from this work that L-eflornithine is much more potent. So if you compare the absolute numbers there, we have a 9-fold higher in vitro potency for L-eflornithine. And the good thing here is that now we can use the data and this new knowledge to predict in vivo efficacious doses if we would go for an L-eflornithine treatment. So moving on to the second part, where we look at the PD modeling. Here we have data from 3 clinical studies. And in the clinic, it's only racemic eflornithine that is currently used. So we have, in one of the studies, racemic eflornithine was dosed intravenously as a monotherapy. And in the second study, we had intravenous eflornithine together with nifurtimox. So this is the NECT, so nifurtimox eflornithine combination treatment. And nifurtimox is dosed orally in this study. And then we have a third study where racemic eflornithine is dosed orally. And from these studies, we then have data if the treatment was successful or not. And then we use the time to event PD model to assess these data and to analyze them. And if we look at study 1 and 2 here with intravenous eflornithine with and without nifurtimox, we look at these curves where we have no event on the y-axis and then the time of follow-up. So these patients were followed for a year to see whether they had an event or not. So if the treatment was successful, the patient was determined to have no event. You can see that for intravenous monotherapy, we have about 97% on the observed data here, and then the model prediction here in gray, describing that data. And for the nifurtimox eflornithine combination treatment, we have similar values where 97% of the population in this study did not have an event, and the treatment was therefore deemed as successful. In contrast, if we look at the data for the oral monotherapy, you can see from the observed Kaplan-Meier curve here that already after 6 months, around 20% of the population have experienced an event, so the treatment was not successful. And the model prediction is much more wide, ranging from down to 48 up to 86% of event, and mainly due to that the study population here is only 25 patients compared to the other studies where we have much more patients. But nevertheless, we could from this data or from these observations conclude that intravenous monotherapy and nifurtimox eflornithine combination treatment are superior to oral monotherapy. And these are all racemic eflornithine, so the 50-50 mixture of the two. So what we want to do next was to use the in vitro data we had. You maybe recognize the curves here where we have D-eflornithine in red, and this is just the estimated in vitro data line. And in green here is L-eflornithine with a higher potency. We then wanted to estimate how would the potency line look for this if we would dose it orally, if you like. So if you remember from the introduction, if you would dose racemic eflornithine orally, you would have twice as much exposure of D-eflornithine compared to L-eflornithine. So this purple line here is then illustrating the potency for one L molecule and 2 D-eflornithine molecules. So you can see there's a potency shift. We have a lower potency for that combination of one L molecule and 2 D molecules. We then use the difference in potency for these two to be able to say something about a potential efficacy for an L-eflornithine treatment. So using our base models from the 3 studies, where we have the intravenous monotherapy and nifurtimox eflornithine combination therapy, and it's maybe most evident for the oral treatment down here, where you see that we have a median survival in the oral racemic eflornithine monotherapy arm at 68%, with this wide confidence interval for the model. If we then would simulate a scenario where the patients would be treated with L-eflornithine instead of racemic eflornithine, you see that the survival goes up, which is good. So it goes from 68 on a median up to 80% as a median predicted survival in this study. However, we still have a wide confidence interval but maybe most evident, we are still not on par with the intravenous monotherapy and the nefertimoxiflornithine combination therapy dosed intravenously. So we concluded from here that L-eflornithine is still an inferior therapy compared to the intravenous therapies we have here. And I should say here that in these studies, the doses are ranging at 400 to 500 mg per kg per day. So in this oral study we have quite high doses, which is seen for the eflornithine therapy, also for intravenous treatment. And then if we use the same dose, but for L-eflornithine, we have this median survival of 80% against late-stage jihad. And as I said, we concluded here that monotherapy is unlikely to be efficacious at these doses that are clinically relevant. And therefore, the suggestion is then to look into the possibilities to have a combination treatment where L-eflornithine could be combined with other available treatments. But from here, we also wondered or thought about the pharmacokinetics, where we have a lower absorption of L-eflornithine, and if it would maybe be possible to have an enhanced or better absorption for enantiomer L-eflornithine. And to test that, if we could have this increased absorption for enantiomer treatment, we performed a study in Sprague-Dawley rats, where we have L-eflornithine, that we dose orally via oral gavage, and then take PK samples over time. And then we compare that head-to-head with L-eflornithine dosed intravenously, where we would then get the absolute bioavailability. So that we call study arm 1 and 2, where we look at the L-eflornithine's absolute bioavailability and PK. We then compare that head-to-head with oral and intravenously dosed racemic eflornithine. So we then can look at if the absolute bioavailability goes up or not for L-eflornithine when D-eflornithine is no longer in the formulation, as on the left-hand side here. We also have a fifth study arm where we have inserted a microdialysis probe in the central nervous system, namely in the third ventricle of the rat brain. We do that because the parasites at late stage jihad have invaded the central nervous system. We would then want to use these brain data, if you like, or third ventricle dialysis data to be able to say something about the brain penetration or how the exposure looks in the third brain ventricle, in rat at least. And we have to up the doses here to be able to have levels in the microdialysis samples that are above the lower limit of quantification. And we studied this via oral gavage dosing as well. So for the modeling for thirsty people, I just want to show you our structure model. It's quite simple. One compartment PK model with transit compartment describing the oral absorption. And the data was then acquired via in-house bioanalysis using a validated method. So the plasma PK is a one compartment PK model in this work. And to describe the dialysate concentration we then have in and out rate from the central compartment to the brain compartment, if you like, or the brain dialysate compartment to describe this data. So if we start by looking at racemic eflornithine and looking at if the D and L-eflornithine pharmacokinetics were different here, we could conclude here that the clearance, volume of distribution, absorption rate were similar for the two. However, which concurs with previous or data from the earlier work, is that we have an anti-selective bioavailability. So higher absorption and higher bioavailability of D-eflornithine compared to L-eflornithine. And then if we look at the brain to plasma ratio here in the rats, we see no difference between the plasma and brain ratio for D-eflornithine and L-eflornithine, suggesting that there's no enantioselective process governing whether we have brain uptake or not. So the enantioselective process in the GI tract or the gastrointestinal tract is not taking place in the blood-brain barrier. And then if we look at the formulation with enantiopure L-eflornithine and compare that to L-eflornithine dosed as a racemate or in the racemate, we see again that we have similar PK profile when it comes to clearance, volume of distribution, and absorption rate for these two, but also that we have similar bioavailabilities. So the bioavailability did not go up if we would dose L-eflornithine as an enantiopure formulation, suggesting that it will not be a clinical benefit to dose an enantiopure L-eflornithine in man as well. So the conclusion from this work is that the L-eflornithine showed similar bioavailability, irrespective of if we dosed it as the enantiopure or racemic L-eflornithine. There were earlier hypotheses that with some type of complex formation could happen between L and D-eflornithine in the GI tract. So by taking out D-eflornithine from the formulation, that complex formation would then are then suggested to go away. But since we didn't see any increase of L-eflornithine exposure, we are comfortable by concluding from here that this complex formation does not occur for L-eflornithine in the racemic mixture and is not, therefore not affecting oral absorption of L-eflornithine. And as we saw for the racemic eflornithine, the brain uptake is not enantioselective in the rat. And now we want to use these findings from this work to be able to say something about clinical pharmacokinetics, namely that the oral absorption or bioavailability is similar in the Sprague-Dawley rats for the two enantiomers and therefore is also similar in human. So to use these three parts moving forward, we then move to the clinical pharmacokinetic modeling. And here we have data from the clinical study with oral racemic eflornithine. So in this study, we have 25 patients, and they were stratified in two groups, where we have one group being dosed 400 mg per kg per day, or 500 mg per kg per day during 2 weeks. And in this study, the cerebrospinal fluid will also sample via lumbar puncture, where you have a needle and put it in the spinal cord, and then you could take cerebrospinal fluid on day 10 and day 14 from these patients. And the clinical PK of eflornithine is previously described with a 2-compartment PK model after oral dosing. And what's new here in this work is that we also have a cerebrospinal fluid compartment, or a surrogate for brain, if you like, compartment, where we're in and outflow from the central compartment to this cerebrospinal fluid compartment. So if we look at some plots here with data, on y-axis we have drug concentration in plasma or cerebrospinal fluid for L-eflornithine, and then you have the model predicted mean concentration, and then a 95% confidence interval from the model for L-eflornithine and D-eflornithine. And you can see here that we quite well can predict the CSF or cerebrospinal fluid concentration for both L and D-eflornithine. And using this model, we also compared or did external validation, where we have literature data from a publication by Milord et al., where they've also measured cerebrospinal fluid concentration of eflornithine, and we are also able to predict those cerebrospinal fluid concentration using this PK model. So with this at hand and this PK model, we then wanted to do a probability of target attainment analysis. So in short, what that means is that from clinical observations and historical knowledge, it's known that you need about, we know what level of CSF concentration or cerebrospinal fluid concentration you would like to have a high probability of cure. So for racemic eflornithine, you want a level above 50 micromolar. And then by compensating for that as a cutoff or target threshold, we could then use our potency difference for L-eflornithine and racemic eflornithine to be able to estimate the probability of target attainment. So if we have CSF concentrations that are above this cutoff, then we get this type of plot where on the y-axis you have the probability of target attainment, and you want to be above this. It's an arbitrary line, yes, but still have a high probability over 90%. So we suggest here that if you're above this line, you're in a good position to be cured. And then on the x-axis you have doses, so daily doses at mg per kg per day, and not all of these are clinically relevant. You remember from the clinical study we had 400 to 500 mg per kg per day, and we also wanted, of course, since we have the model at place, to look at what would happen if you would then have doses that are not clinically relevant but still higher. So what you can see from here is that L-eflornithine as monotherapy, symbolized by triangles, you need doses that are around 750 mg per kg per day, and there are different colors based on how often you dose the drug. So the red dots or the red symbols indicate that you dose eflornithine or L-eflornithine 2 times daily, blue is 4 times daily, and green is 12 times daily. And then you might think, why 12 times daily? Well, we want to explore this as higher dosing frequency is potentially better than a more infrequent dosing. And eflornithine is a quite soluble compound, so it's feasible from a chemical perspective or physics perspective to dissolve a lot of eflornithine and drink that over the day. So this 12 times daily should maybe be more seen as a continuous intake over the day, whereas the 2 times and 4 times daily is more strict regimens on a clinical level, if you like. But it's more of a simulation scenario to see what would happen. But L-eflornithine as monotherapy at 750 mg per kg per day is a very high dose and above what was the highest dose ever used in a clinical setting for oral dosing. But then if we would use L-eflornithine and nifurtimox as a combination treatment, the story is a bit different. So here you have the circles where already at doses at around 375 mg per kg per day, we have a target attainment that climbs above this 90% probability, suggesting that the combination treatment with 15 milligrams per kilogram per day of nifurtimox together with 375 mg per kg per day of L-eflornithine could be efficacious treatment. So from here, we concluded that the clinical pharmacokinetics were adequately described here by the pharmacokinetic model. Similarly, also, as we saw in the rat, there was no enantioselective exposure of L and D eflornithine in the cerebrospinal fluid in late-stage GHAT patients after oral dosing. So similar finding as for the in vivo part. And based on our PTA or probability of target attainment analysis, it suggested that L-eflornithine doses at 375 mg per kg per day in combination with nifurtimox could be a potentially efficacious treatment. So to move over to more major conclusions, we see here that L-eflornithine was the more potent enantiomer in vitro. We also conclude that L-eflornithine as the monotherapy, as seen from the PD modeling work, would be inferior to current intravenous eflornithine treatments. And we also say that the in vivo pharmacokinetics after oral dosing of enantiomer pure L-eflornithine is similar. So there's no real difference in the PK if you would have enantiomer pure or racemic eflornithine and dose that in vivo. And we translate that to human using the fourth part here, where we look at oral L-eflornithine dosed at 375 mg/kg per day in combination with nifurtimox, and that could be a way forward. And just to point direction here, that the current treatment is intravenous treatment with eflornithine. So for any type of eflornithine-based treatment, you can see that there's a burden both for patients, as you would have this more invasive route of administration, but also logistically, as right now there is a lot of voluntary work, and also work from the World Health Organization to distribute sterile infusion liquid and drug to the treatment centers. And I hope that the message from today's talk is that we have used PKPD modeling, and our approach here have shown that there could be a potential way forward where L-eflornithine is used together with nifurtimox as a combination treatment, and that our work here using in vitro, in vivo, and also literature clinical PK and PD data shows how you can work in this disease area, and that there might be a future with an L-eflornithine based treatment. So with that, I would first of all like to thank you for listening in. It's been a great privilege to be selected to present here today. But of course, I also want to extend my gratitude and say thank you to all collaborators and co-authors, and also funding agencies who made all this research possible. So with that, I'd like to hand over to you guys to fire away with questions that I'm more than happy to answer. Thank you very much.
Thank you, Michael, for a very interesting webinar. And we do have some questions. I'd like to remind our audience that you can ask questions to Michael by putting them into the questions pane in your GoToWebinar side panel. And let's start with the questions we have, and we'll take them as we go. From the observations you showed, parasites were not killed by the drug completely. Will they regrow again?
That can happen both. So clinically, we have something called reoccurrence. So yes, the patient, if they are suboptimally treated, the parasite can hide, if you like, both from the immune system, but also the drug treatment, and then reoccur. So patient can get, so to speak, reinfected or have symptoms from the same parasite once again. When it comes to the in vitro data, we see, so we get an Imax of around 100%, and then the model estimate is not 1.0 for all, which is, yeah, we've looked into that, but we know by microscopic measurement that all parasites were gone when looking at the on the plate, but something in the fluorescence measurement that is a baseline dancing there maybe that gives this, that the Imax is not 1.0.
So this drug, eflornithine, I'm not going to pronounce this correctly, eflornithine,
Yep.
Sorry, works against one form of the parasite. Does it work against the other form of the parasite?
That's a good question. So eflornithine is inhibiting an enzyme called ornithine decarboxylase, which is present in parasites, obviously, but also in human cells. So it's a quite vital part in us as well. And apparently the trypanosoma brucei gambiense parasites have a different turnover of this enzyme compared to the rhodesiense as compared to human cells. So the turnover is much slower in gambiense. So therefore eflornithine works in gambiense type. And then for regimens, the turnover is so quick that the therapy is therefore suggested to be ineffective. So that's also why we as the treated patients or humans, we are not as affected by the treatment as the parasites. And then when it comes to other type of trypanosoma parasites, I must say I'm not aware of any effect in, let's say, in Chagas disease or others. So it's mainly or only used clinically for trypanosoma brucei gambiense infections.
Why was a one-compartment model used in mice, but a two-compartment model used in humans?
Yeah, that's a really good thought a lot about that. Why? So there is previous data around the PK in vivo. So previous work from the same lab where I did my PhD, where we have higher doses. So I was at 75 mg per kg for L-eflornithine, or 72 mg per kg, and then we picked that level not to deplete our whole stock of L-eflornithine. And I think if we would have higher doses as predecessors in the lab have had with the racemic eflornithine, we would then get a two-compartment PK profile. But I think the sensitivity of the bioanalysis together with the doses picked for the study didn't give the full profile, if you like. So the oral profile looks like a one-compartment profile. So it's more of a dose level thing more than the true reality, if you like, for the pharmacokinetics of eflornithine.
What are the physiological characteristics considered during the CSF compartment modeling?
So we go about this quite empirically. Since we have quite granular data, so the CSF, if we look at the rat data, at least we have a quite good concentration time profile, because every 30th minute you can take a new sample from this microdialysis fluid. So with that, we're quite sure we have, let's call it identifiability, or we know that we're measuring in the right place at the right time. So we have a good translation of the plasma and dialysate concentrations we see. The model is not taking into consideration different, say, interstitial fluids and CSF bulk flow and so on, that I know can be incorporated using either PBPK modeling or some type of minimal PBPK modeling. But we chose an approach where we kept it with compartment modeling or just having a brain compartment and this plasma compartment to be able to describe this and translate it over to human in that way.
What is the gastrointestinal toxicity of L-eflornithine?
So if you treat a patient or any human with the high dose at 400 to 500 mg per kg per day, you have development of GI-related adverse events which are most prominent. So we have diarrhea, vomiting, malaise, nausea. And interestingly, so normally if you would look at the drug and you look at the toxicity profile, you would expect to have higher toxicity for an IV dosed drug compared to oral dosed, so that these systemic levels are driving the side effects you see. But eflornithine is actually the contrary, where same dose of intravenously dosed eflornithine is tolerated, but it's not tolerated after oral dosing due to these side effects that I just described with vomiting and diarrhea and so on. It's a flipped picture for eflornithine, interestingly enough.
Could you use your modeling work to model the potential toxicities for L-eflornithine?
Absolutely doable. So from the work with 25 patients, there are records on clinically relevant and also drug-related adverse events. We looked at that early data to see if we could see any indications if L or D eflornithine would be the one driving those side effects, and there was no clear cut there, mainly because we only have 25 patients here, and they are, as I said, stratified in 13 and 12 patients, so it's quite a small study. But absolutely doable to maybe use that data and look at the PK profiles from the individuals and look at the toxicity and also grade of toxicity they have. It's nothing we have endeavored so far, but it's a real good idea.
So when you look at the combination therapy, are there drug-drug interactions with this? Because this is going after a common enzyme.
Yeah, exactly. So we think about drug-drug interactions as if eflornithine will be the victim drug. Eflornithine is not metabolized in any, not in rats or humans, so we have no known metabolites. So it's mainly renally eliminated. So that is good in a way that if another combination drug is, let's say, the perpetrator and gives inhibition or induction of an enzyme, that would not suggest not to affect eflornithine's pharmacokinetics. And on the other hand, I don't know anything about eflornithine as the perpetrator drug, so I don't know if it inhibits or induces any of the, let's say, the cytochrome P450 enzymes or other drug metabolizing enzymes. But I would be, so for the drugs available now, it's only been tested together with nefertimox, and that seems to be a clear profile, if you like. So that's approved and good. So it's not too far-fetched, in my point of view at least, that L-eflornithine would have a similar, i.e. good drug-drug interaction profile together with nefertimox.
You mentioned that the IV form of the drug, which is currently used, is not as easily handled given the rural areas where it might be used. Would the oral drug obviously might be a better substitute. Is L-eflornithine stable, and would it be a stable alternative?
So now I need to think about my pharmaceutical skills. So if we talk about chemical stability and if it's, I mean, it's synthesized or right now as the racemic mixture, and I assume that the chemical stability, i.e. the stability to ship it from the manufacturing sites to logistic sites and now to these rural parts would be similar. So that would hopefully not be a problem. What else to think about? It's also about, so L-eflornithine or any racemic or any enantiomer drug could racemerize and get back to be both enantiomers. And from the material we have and the time frame we worked in, I've been able to save L-eflornithine in the lab and analyze it over time, and it's not converting back in that sample or those samples back to being the racemic mixture, which is good. But obviously those tests is beyond the scope of the work I did, but no clear indication that it's unstable, that I can say. So we have, for the time frame I work with this substance, a good stability in that sense, but that of course needs to be tested if scaled up and then brought forward.
So the current drug is the racemic mixture. Would there be a toxicity, a lower toxicity benefit of going with just the L-eflornithine, or can you expand on that?
Yeah, looking at the side effects profile or adverse event profile, as I said, if you dose it orally, you have less tolerability compared to intravenous dosing. So that suggests that if you could decrease the oral dose from the tolerated 500 mg per kg per day down to something else, in our case we landed on 375 mg per kg per day, but nevertheless less than 500, then that would then bring us forward to say that we would have a lower risk of adverse events. Of course, it could be that the side effect profile we see is due to L-eflornithine to a higher extent than D-eflornithine, and that is unknown. So that should be monitored moving forward. But from the small data set we have from these 25 patients, there was no clear indication that it was one of the enantiomers exposure or gastrointestinal concentration that was driving the side effect profile we see. So potentially we could have a better side effect profile for L-eflornithine dosed orally now.
Great. I think we have addressed all of the questions. This has been a fascinating webinar, and I'd like to thank Mikael for presenting today. If you'd like, we can pass the questions on to Mikael so he can see who has asked and perhaps contact these people individually for those of you who have additional comments. Thank you again, Mikael, for a wonderful webinar, and I hope to see you and everyone at a future webinar. Thanks again.
Thank you very much.
Have a great day, everyone. Bye.